health informatics. He's also the founder and executive director of the Foundation for Living Wellness and Health. Is a globally recognized expert in WHO calls when you call communication technologies or e-health, and also mobile health. And clinical engineering community calls it clinical engineering and information technology, where medical device and electronic health records are deployed together to improve clinical outcomes. Dr. Sloane is also a former co-chair of the board of directors of Integrating the Healthcare Enterprise, IHE International. So it's important to mention that this webinar was originally presented by Ricardo Silva. So Ricardo presented in August the 30th in Spanish. And we thought it would be very important to, and thanks to Dr. Sloane, to present an English version of the webinar. It was very successful webinar, lots of interest, and our Redacted colleagues along the region. So we decided to, because it's very hard to have translation in this kind of webinar, and also very costly. So we're very thankful to Dr. Sloane to English version of the webinar. So today the title is the local and global clinical engineering and information technology in the context of health technology assessment and health technology management. So for us, it's very important. We call this kind of an integrated approach, because we went to, as that says, the HTA network of the Americas, but we're trying to work together the concepts of not only the concept of assessment, but also the management side, and how can we integrate it, those concepts. So that's the why we decided to promote these webinars. I would like to also thank other colleagues. Tom Judd, I think he's with us for this partnership with the IFMBE, also with other colleagues from IFMBE, Toby Clark. I'm not sure if he's connected, but Toby Clark is also a very important contributor, and other colleagues from IFMBE. So thank you very much. So I think we are ready to start, and I would pass the floor to our very special guest, Dr. Elliot Sloane. Dr. Sloane, thank you very much again. You have the floor. Go ahead.
Thank you. It's an honor and a pleasure to be able to present this material and share it. First, I want to give a credit to Ricardo Silva for organizing these slides so nicely. It really is an excellent way to communicate and share a lot of thoughts. By way of background, for the introduction, I really started working, you'll see down at the bottom, I've worked with the Pan American Health Organization since 1978 as an advisor, and largely in this crossover area of clinical technologies and information technologies. And in that early effort, it was nomenclature, and here we are 40 years later, still, and again, wrestling with nomenclature. But a lot has transpired, and we've made an enormous amount of progress. My work at ECRI Institute led to work in the medical device and pharmaceutical manufacturing field, and I have had the pleasure of being an academic researcher and advisor for about the past 20 years. My colleague, Dr. Silva, and I have worked together for nearly 20 years when I met him in Havana, Cuba at a Chorale conference in 2001. And we have worked very, very effectively over the years, and the last several years with his joining us in the Florida area has been very productive. By the way, that's where I'm talking to you from, the Southwest Florida area near Tampa. Our goal is to familiarize you as our clinical engineering colleagues, with the state of the art and the evolution of this convergence of clinical technologies and information technologies. And we will give you a number of perspectives. There are many names for this. One of the current ones that's agreeable is digital health. And there are other formulations that have come and gone and that apply to different segments of the field, and we will try to make those clearer. Information systems have affected all of our lives in ways that we never would have suspected. It's only about a dozen years that the iPhone and apps have become the norm for personal technologies. It's only a decade since the iPad emerged. And we take for granted today concepts like cloud, Bluetooth, Wi-Fi, cellular phone, text messaging, and all of these are being adapted and adopted for healthcare as quickly as we can. In the United States, in the center, talks about our 10-year initiative with President George W. Bush that started in 2004, and both the Obama and Trump administrations have supported these. They benefit the public quite substantially. In my work with WHO, PAHO, and IFMBE, most recently last week in Rome at a International Clinical Engineering and Health Technology Management Conference, we are seeing these efforts blossom all around the world. When I say these efforts, the integration of text messaging, cellular networks, broadband, apps, digital sensors to healthcare, because when the day is done, as I've learned in my work over the past 40, 45 years with WHO, we all love our children. We all love our parents, our nation, and we want to use the best technologies the most effective way we can. And certainly information technologies are going to be part of that, that activity and growth. We have the fortunate benefit of support from IFMBE's Clinical Engineering Division, and Tom Judd, who has joined us and has so much support in this area, is a really important ingredient to this discussion. Tom himself, as a former executive with Kaiser Permanente and now as president of the CED, is really well aware of the opportunities and also the challenges that face us in deployment and effective use of these technologies. We have some very nice journals and open access materials, and I would say that all of us are committed to making our materials and information available in an open access, open source form so they can be used in your country, wherever you are. Which reminds me to ask each of you, if you would, take a moment in the chat box and identify yourself, the country you're from, and perhaps, if you're comfortable, the individual institution, so we have an idea of who is participating in this program. And also, when you find our links and our email addresses, we invite you to communicate directly with us. The World Health Organization has been working on e-health or digital health or the convergence of technologies for easily a decade and a half. I have worked with Adriana Velasquez. I have worked with Antonio Hernandez. I have worked with Alexandre. We have had many discussions over the past 15 years about how we can accelerate and support the evolution and application of information technologies in a thoughtful way, an effective way that adds value to our communities, not just cost, burden, and risk. The recommendations that have currently come out identify specific ways that countries can work on selecting the proper technologies that are appropriate to your needs. And needs are often regional, not just national. Harnessing the power of technologies, digital technologies, is essential for achieving universal health coverage, because we're all aware that the cost of sending someone to a hospital, both in transportation, risk, infections, and delay, are very substantial, and we now have the ability to reach out and touch people through telecommunications, ICT, at the time of need, in the place of need. And the use of digital technologies offers new opportunities to improve people's health, is another way of expressing our desire to improve or ensure access and fairness and equity of clinical services to everyone, everywhere. This is not a new concept. The radio doctor was predicted in 1924. I have articles that were written in the 1960s. The concept of being able to use communications to reach patients and to help physicians help each other is not new, but it is a lot more complicated than just reading a news article or sending a text message. And that's what we're all about, helping us get from just the digital ones and zeros, just the heart sensors or the blood pressure sensors or the pulse oximetry sensors, to the clinician, the caregiver, the patient, the family, the nurse, the medical records organizations, the ministries of health, so that good planning, real-time planning, can be taking place. An example is digital imaging. It's a long journey. As it turns out, my father was a radiologist. I grew up as a young kid in a small hospital. I spent my summers and nights in the darkroom developing films. And so I have had a unique vantage point to look at digital imaging and the slow but steady replacement of films and toxic chemicals with electronic acquisition, precise electronic acquisition of radiologic images from almost every modality. And I've watched the earliest gamma cameras, ultrasound, and other technologies be introduced in this field. And now today, in the green on the right, we've gotten rid of the toxic chemicals. By and large, we've really improved the quality problems. It was not uncommon to see a technician have to take the same chest x-ray 2 or 3 times because the chest x-ray was either overexposed or underexposed. And the computer now is capable of monitoring radiation doses, controlling and reducing radiation doses for mammography. It also now has tumor diagnostic capabilities, and all of these improve safety outcomes. And I have to say, my father at almost 90 had the startling opportunity in the last years of his life to be able to see in the emergency department his own chest x-ray that showed his own pneumonia, and he was really quite amazed and quite thrilled that the technology had developed in his own lifetime. The transition is not a simple or seamless one. We've had to deal with technologies like archiving and communication systems, or PACS, connecting them to electronic health record systems, hospital information systems, radiology information systems, laboratory information systems. That's part of the work I do with Integrating the Healthcare Enterprise, IHE, which is a global initiative, of which there are several in Latin America as well. The Veterans Health Administration started its own teleradiology network in 2007 so that it could reach out to smaller towns, smaller villages in the United States and provide radiology support. And now it is very common in the United States, especially at night, to have someone elsewhere in the world, in India or in Australia or in Europe, reading x-rays for emergency room physicians in order to help accelerate the patient care and reduce the costs. We have many faster processors now to do digital imaging. Some of them, oddly enough, emerged out of the gaming industry. So computer video games, which required very sophisticated 3D resolution and the ability to do real-time motion and multi-sensor integration, have been adapted to healthcare applications very nicely. When the iPad arrived in 2009, in fact, within a year, there were FDA-approved radiology display and even oncology planning software that emerged as apps. So, you know, our ability to innovate with these tools and apply clear goals and then test and field these technologies is really accelerated through the information technologies side of things. A medical device today is a largely inside many of the times, perhaps 80 or 90% of the time, inside is at least one or more microprocessors. One microprocessor might be dealing with display, another might be dealing with a sensor, another one might be dealing with analytics, another one might be dealing with communication. There may be only one processor that is running flat out in order to reduce the power demands. But when we're looking at an individual's biologic vital signs, we're not looking at fast-moving numbers for a healthy person, at least. We're looking at blood pressures or heart rates or respiration rates that are moving at a reasonably a slow velocity. Of course, not true for the emergency department, ICU, or other settings. The data now, since it is in digital form inside the device, we have come up with portals and methods and APIs, application programming interfaces, that allow us to move the data from the device or sensor into the local area network, into a hospital server, into central station monitoring, and we're, of course, acquiring the need and challenge to have firewalls to protect these technologies. If you are curious about the risks, you only have to type the word hospital and ransomware, or doctor or electronic medical record and ransomware, and you will find an ongoing battery of attacks and assaults on medical information. So that's an aspect of this. It's an unintended consequence or challenge. And our ability to go out through the internet around the world to get technical support, manuals, order parts, work with telemedicine, sharing the medical information with other clinicians, other advisors, other researchers, is now greatly enhanced because we have a very standardized way via the internet to share information. And also I'll mention that through our work with integrating the healthcare enterprise and HL7 and HIMSS and the ITU and WHO, these standards are becoming the norms internationally. It doesn't happen overnight, but it is happening finally in our world. We have edge devices which are gathering information from many different areas. For example, emergency medical systems, ambulances, helicopters. We have many forms of connectivity that include largely wired, still heavily wired systems. Bluetooth, the Zigbee, personal health networks, and many things emerging in this field. Of course, more wearable sensors. I've been wearing a Fitbit now for about 2 years, and it's kind of fascinating to see the data that it is able to provide to me about my daily activities. We have the foundational tools that we need. We can describe this as an Internet of Things, not so much as a specific device like a Google or a Google Assistant or a Google Home or an Alexa device, but we are talking about all of the sensors and medical devices as part of an extensive internet of all sorts of things. The question was asked, will we be sharing the slides? And the answer is yes. That will happen when we're done with the presentation. Foundationally, there's a lot of work that has to be done and is done. We might call this backroom work, but it really is in the day-to-day care of the patient. We have to deal with workflow, planning, scheduling, data flow. If you're in the operating room and the surgeon is removing a tumor, the surgeon is going to send a pathologic sample to the pathology lab, and they need to know very quickly whether they have completely removed the edges of the cancer or not before they proceed, as one example of workflow. So how we get this information in and out of the various systems is part of the challenge in an enterprise. And we're working more and more on how to do similar things at the home level or community level for patients who are at the end of a telephone or cellular network. There's a lot of work going on in analytics that has to do with predictive analytics. For example, is a person going to be prone to a heart attack or arrhythmias of some sort, or an episode of high blood pressure or asthma? We're using tools like machine learning and natural language processing, and we're doing a lot of advanced analytics to help us visualize where emergent problems might be. I've worked with people in the European Union at microclimates and identifying where carbon monoxide and diesel emission particles accumulate during rush hour that can then trigger asthma attacks, for example. And the ability to notify individuals or automatically modify climate controls in a long-term or assisted living or home setting is becoming very feasible. And then the integration of the information into an enterprise, whether it's a Ministry of Health, a hospital, a clinic, the ability to look at big data such as the effect of a new medicine or a new treatment or a new vaccine in helping eliminate an emerging risk syndrome or a combination of syndromes. And a syndrome we don't talk about nearly enough is aging. We have more and more centenarians, people living to 100 years old around the world. And the nature of the human body is that we have not one illness now, but 3, 4, or 5 comorbidities, and they interact. And the medicines and treatments and activities and food and environment all interact in very unique and novel ways. So we might call this medical devices 3.0, the era of devices that interconnect with the information or ICT framework and also become part of the world around us as more and more people have the opportunity to have cellular connection to data and communication. This is the traditional pyramid of data and knowledge. The raw data, an individual blood pressure reading doesn't tell us very much. An individual cholesterol reading or pulse oximetry reading doesn't tell us very much. May identify an immediate distress circumstance, but it doesn't tell us about trends. As we begin to gather information that we can begin to draw conclusions from, we move to the area of information, but the information itself doesn't make decisions. A decreasing blood pressure, which indicates hypovolemia, or hypotension, or both, is useful, but it doesn't tell us how to treat the patient. We need more context. We need to know if the patient has been exercising, is ill, has just taken a medicine, has just fallen. So that moves into the area of knowledge and the concept of what does the information need? What are our steps? What processes or best practices should we follow? And then wisdom is really the penultimate peak. And that's very complex as we deal with people who are in their 90s and 100 and 101, 105 years old. We get into ethical and complex questions about what is the best decision for that person, for the family, in terms of whether they should have, let's say, a surgical procedure or a chemical treatment or an implant. And I've had that experience dealing with my mother and my father, and I can tell you that those are not answers that are easily found in any dictionary. Those are societal discussions and family and community discussions. The modern hospital that we're all dealing with, even in smaller countries and in smaller towns, the application of some communication technologies is finally emerging. In the hospital in Beijing, China, for the People's Republic of China Red Army Hospital, it looks very much like this, what I'm showing you. Everything is computer connected. The intensive care unit is connected to the pharmacy. The pharmacy has robotic medication management and mixing and formulation systems. That's fascinating to stand in the center of China's excellent healthcare system and watch how the best practices are being applied. And I was traveling with a colleague, an executive from Kaiser Permanente, who said, you know, that's exactly the kind of stuff we're doing in our hospitals in the U.S. More typically, our current state of the art in most hospitals is more modest, but we are typically trying to make sure that if we have a lab result, it can be sent to the physician or surgeon or records department by a text or by an email or by an attachment or by a direct connection to some kind of medical record keeping system, so that we don't have duplicate data entry, so that we don't have lost data, so that we don't have delays. 20 years ago, when I was working in the Central European countries after the collapse of the Soviet Union, they were back to using pieces of paper to get lab results back to the intensive care unit. Sometimes it was half a day, sometimes even the next day, before reports were provided, and it was too late for some of the patients. The 21st century hospital is certainly oriented towards full internet protocol design, wireless and wired networks, optical networks where possible, comprehensive patient and staff-centric EMR. So the ability for a physician to find all of her or his patients, or for a physician or nurse to find the data about a particular patient at a particular time is emerging. It is not easy work. There is no perfect electronic medical record software system on the planet yet today, and there's a lot of work being done to improve that. We're doing a lot of work in the smart building, because a lot of the environment of the building, the temperature, the humidity, the climate control, the movement of air, and filtering of air all affect the health and outcomes for the patient and the wellness of the staff. Automated logistics, ensuring that products and supplies don't run out. If you haven't worked recently in an operating room, you should make the opportunity, if possible. There's nothing more illuminating to see an anesthesiologist work in absolute frustration. Their laryngoscope has a dead battery or a dead bulb, and they can't intubate a patient for surgery, or the surgeon runs out of simple supplies like sutures and scalpels. And then eco-friendly infrastructure, reducing the requirements and waste of utilities and resources are all very, very, very important. We have digital hospital deliverables that are really, I've described this as the sentient hospital in some previous articles, the smart hospital, the thinking hospital, thinking buildings where automated security, who enters the building, who has not left the building that should have left the building, integration of all of the alarms and patient safety systems with the building management systems, automated logistics so that people and resources, supplies, needles, syringes, surgical supplies are at the right place. There are more and more hospitals using very simple robotic delivery systems to move technology through the hospital. There are more pharmaceutical and supply companies using simple robotic systems to ensure that supplies are delivered to the hospital. And of course, reducing the waste. And everyone is looking today at a lower carbon footprint to ensure that the service provided to the hospital and the community are efficient and effective. So there's some examples of robotics, and honestly, some of them are much, much smaller and simpler than these. And I've been in places where the robot is no bigger than a shoebox, kind of like a pet, moving a supply from one part of a floor to another to support patient care. RFID, we have RFID in the airport, we have RFID in retail, the ability to have tags on various items so we know where they are. If you cannot find a particular surgical instrument, you may stop an entire surgery from successful completion. If there's an RFID tag on it, you've accelerated, increased the possibility and probability of finding that for the patient care. We also have two areas of emergent and somewhat different applications: telehealth and telemedicine. Telehealth is broadly the ability to use communication and information technologies to connect the caregiver or the network of caregivers to the patient, as opposed to telemedicine, which is often used as a way to connect caregivers to each other. So in telemedicine in the United States, if a patient has to be admitted because of a psychiatric problem, there are a number of situations in which a psychiatrist in another state even can make a diagnosis and approve the admission of the patient, where that patient might have been held for 24 hours until a psychologist could visit the hospital and interview the patient. On the telehealth side, we're talking about this very much Internet of Things, wearable sensors, very small and inexpensive adapters that can take blood pressure, heart rate, respiration rate, weight, and other readings for and with the patient, and then allow either the patient to make better decisions, their parents or family caregivers, neighbors, or visiting nurses, or a hospital team. There is an ongoing rise of healthcare costs around the world. We are really working everywhere I travel, trying to look at readmission, at least unintended or unnecessary readmission, having patients come back because they did not have antibiotics before, during, or after a surgery, for example, is one way that in some surgeries we're able to assure reduced readmissions. We have an ongoing shortage of specialists in rural areas, and that will only increase as the global population increases. A rise of chronic diseases I mentioned before, especially with the aging population. Improving collaboration between physicians and different healthcare organizations, and that happens everywhere among every country, because most countries have both a public, a private, and a private healthcare system, and those systems don't talk. And even between the public healthcare systems, many of those silos don't communicate, and even within a hospital, many of the departments don't communicate, if not because of technology, because they actually have different language and different concepts of technology application in healthcare. Ultimately, improving patient and community satisfaction, assuring that patients are able to get access to the kinds of specialties that they need at the appropriate time to intervene, save lives, reduce suffering, reduce costs, and improve care. Telemedicine and telehealth may use store and forward methods, which means like email. If you're not connected to email because you're on an airplane, the information is being stored, and when you land, get all of your emails forwarded to you. We also have real-time capabilities, more and more abilities. This is something that Dean David, when he was head of Texas Children's Hospital, was doing throughout Latin America and Asia, and that was 25 years ago with very specialized equipment. Today, tools like GoToMeeting and Zoom allow some pretty fabulous real-time consultations between physicians, caregivers, nurses, and others. And we're really leveraging this, allowing physicians who are moving to the patient. This is going back to the way medicine was delivered before I was born in the US, where the physician went to the patient. There was no real large hospital-centric system. And then the ability to have remote monitoring for patients. I have published a number of papers on this topic, and I would be pleased and honored to share those with you. Simply send me an email, and I'll some of the work that is going on in that space. We have the concepts of televisits and teleconsultations. Kaiser Permanente published an article, I think 3 or 4 years ago, that said more than half of their patient visits are now virtual. That the patient either doesn't have to come to the hospital, or they only have to go to a satellite clinic to get their patient care and examinations and advice and guidance taken care of. And then telemonitoring, the ability to support patients in place. In the U.S., it's getting, to my sense, even a fairly exotic. Mount Sinai Hospital in New York has a remote intensive care framework where they can send patients home with all the intensive care equipment that would be in the intensive care unit. And they claim their studies have shown very increased cost effectiveness, satisfaction, safety, and outcomes in that process. And then at the bottom, telehome care. This really is I think the great unexplored and opportunity in the 21st century, which is providing care for people, whether they're patients or not, in their home, in their place of work, in their car, so that they don't have to go to a physician unless there is a serious problem. And you can think of that the way 21st century cars is designed to have internal diagnostics and communication when necessary with the manufacturer or scheduled maintenance activities. The framework for a home environment and the connection between a hospital server and local area network is at an abstraction shown here. There are many ways to accomplish this. Most of them include the internet. Very few of them use proprietary or closed networks. Some of them may use a virtual private network, but still behind the scenes is an internet. and it allows patients to be discharged early. One of my colleagues' wife just had a hip implant surgery, and she went home the same day. To our sense of safety and quality, that's pushing the limits. But the ability to provide connectivity and support for the family and the patient is expanding very, very rapidly. So we have all of these different opportunities. Last night I saw a colleague who is working with children in local schools, and they have a portable eye diagnostic device that about the size of a football, and they're able to do an entire evaluation of each eye of a child and make a recommendation to see an ophthalmologist based on a rapid assessment that's done with that simple device. It almost looks like a game. We have so many new sensors that are well developed: weight, pressure, glucose, medication tracking, temperature. And the beauty of this is these sensors are now all available to connect directly to an app, and that app is now able to connect either on a store and forward role or directly to a information, text messaging, or other system to share the information with appropriate caregivers. And that app can also have threshold sensors or threshold levels to predict and detect emergent risk problems. The kinds of vital signs that we know in terms of whether a patient is okay, these are some of the basics like heart rate, blood pressure, temperature, oximeter, which is tissue oxygenation, the patient's weight and body mass index, and blood sugar. And these are now all measurements that are fairly readily available at very low cost. If we look at Amazon.com in the US, you can find a blood glucose monitoring system based on an app that has been FDA approved that can be purchased for as little as $25, which is a staggering change in the cost and availability of technologies. We have a lot of new interesting peripheral measurement devices, wearable devices. The challenge of all of these devices is that although we know what the normal measurements are for a hospital or physician setting, we're not exactly as precise or certain about measurements at the wrist or measurements at an ear for a tympanic temperature for a child, but we're learning a lot more.
You should probably skip through all of the IoT devices so that you can get to the teaching material.
Thanks, Ricardo. So these are here for the record, which you're welcome to look at. And we have the end result is the creation of an enormous amount of data that is being used by physicians, by caregivers, by ministries of health, by the World Health Organization to get our arms around the health status of our communities, our regions, our nations, and make better decisions. And all of these devices are creating a really powerful network of care, a web of care that could only be imagined 10 years ago. It's being delivered today. We have a number of security challenges with these devices, which is the subject of an entire course that we teach where I'm heading today, or in the next couple of minutes. E-health, M-health, pervasive health, ubiquitous health, these are becoming realities little by little, depending on where you live, depending on your community's access to academic and technical support. And also, of course, now in the area of health technology assessment, we have some profound and interesting challenges and opportunities in understanding how these devices and systems interact, what the costs are, who is needed to support them, and how to manage them, which leads us to our 21st century challenge, which is what are the skills clinical engineers need to continue being the leaders in the support of these technologies. Dr. Silva and I have been working on this and on these kinds of courses for years and years, and these courses have been designed to be adapted by you in your own countries to your own teaching needs. There are skills that are needed in systems and systems of systems engineering and design, network cybersecurity, device and system interoperability, databases and analytics, and the whole area of systems, project portfolio, and life management. Ricardo and I have developed many courses in this space that deal with general health informatics and systems and understanding of how electronic medical record systems work, the underlying database and health informatics tool, health IT ethics, security, and law issues. Also, topics related to artificial intelligence and decision support systems, software engineering, project management, disaster recovery. All of the work that we have developed can be translated and transformed and presented in English or Spanish, thanks to Dr. Silva's excellent bilingual knowledge and capability. All of the work that we have done is based on affordable or free e-texts. So we have never been willing to bind these systems to expensive textbooks from international publishers. The most perhaps expensive book is this $40 ebook that can be purchased and shared by students, which has a world-class current set of information about e-health and digital health activities. I asked Ricardo to add a slide in here in Spanish. Really, the ability to communicate in English and Spanish, which I'm afraid I don't have, but fortunately he and you, many of you have. We have the ability to work with you and share this information so that we can do webinars, we can do training, we can do train the trainers, we can help professors and universities build this curriculum, ministries of health as needed. The question is, are you ready to support 21st century digital health and the growth of health IT? And also, how can we best support you? Again, it's been an honor to be with you today, and I'd like to take the opportunity to open the floor to all of you for questions for me and or Ricardo Silva.
Thank you very much, Dr. Sloane, for excellent presentation. Of course, thank you, Dr. Silva, as well. So since it's the Ricardo was the original presentation in Spanish, as I mentioned. It's a very successful webinar as this one as well. We have more than 40, I think like 45 participants. Also, I would say connections, in fact, because it's many participants join the same connection sometimes. So I would say I would expect around 100 participants right now. So I asked my colleagues Nilda Enriquez and Stephanie Wimejater. Thank you, Stephanie and Nilda, for the support. I asked them to help me with the questions to organize, please. So you also can send. If you want to send the question, please send to me or to Neil. That will be easier. But you also can send to the host. With right now is Stephanie, which is in another computer right now, but she can see. I can see the questions here as well. So in the meanwhile, please prepare questions and send to me or Nilda Enriquez. I would, in the meanwhile, share some information I think is important as well. PAHO has been promoting a series of activities related to health technology management in the last few years. And I would like to mention the activities that are currently being developed right now. One is related to the e-learning training that we with our University of Vermont. So I can see that Toby Clark is connected. So Toby Clark is coordinating this activity for the last few years, lots of trainings and virtual courses. And right now we have a English version of the course on health technology management with 25 participants from Belize, Grenada, Haiti, Cayman Islands, St. Lucia, Suriname, Trinidad and Tobago, and St. Vincent and the Grenadines. The participants of 8 countries, 25 participants. We also organized a very successful workshop last March here in Washington, D.C., we have 16 participants from 14 countries, and we established a kind of sub-regional network for health technology management with the Caribbean countries. And I can see lots of colleagues from the Caribbean here connected, and I would like to thank you all for your participation. Also, in our collaboration with the IFMBE, we also all have this webinar that we are organizing, also the participation in our last meeting of the regulators, medical device regulators, regional meeting that we had in Bogota in September, when we have the participation of representatives from FMBE in Bogota. So I think there's lots of things going on, and I'm glad to share those great news with you. Okay, so back to the questions. I would like to you can ask for the microphone if you want. You prefer to make the questions yourself, or send your message. Okay, so please, we have time. We have 10 to 15 minutes. So please, I think it's a great opportunity, since we have two great experts, very special guests today, Dr. Sloane and Dr. Silva. So go ahead. I asked my colleagues if we have any question right now. I cannot see anyone so far. So
and if you prefer to ask the question in Spanish, that's fine.
Okay, yeah. So it's also possible. So I can see here the participants. So we have Alana Friday. We have Anna K, Arlita Scott, Daksha DeB, Danielle Romero, Danielle Souza.
Maybe we can ask a question on our end, which is what support or assistance do you need or want? I'm sure that you're here because you see this as an area of opportunity and challenge. What are the kinds of support, trainings, materials that would allow you to do a better job as this field continues to emerge and grow?
Yeah, great. I think it's also a good possibility. So so you can share in the course on health technology management, and Toby Clark can share with us his experience. Been very active. So very interactive. So we have a special forum for discussion, and I receive all the copies. I think you have maybe hundreds and hundreds of messages with participation from the course participants. So I know that they are very active. So maybe they're a little bit shy right now. So go ahead with the question of the Silva, and it may be, and also if there's any questions from other, or Toby or Tom Judd, please jump on. Okay, maybe I can start. So Dr. Sloane, in my experience, and as being the regional advisor for PAHO in the last 8 years, in issues regarding health technology assessment, health technology management, also regulation of medical devices. So I've been lucky because I have responsibility for all the life cycle of the technology in terms of regulation, assessing, and also the use of the technology. So one thing that we've been working and trying to promote in the region of the Americas is what is being called an integrated approach. And you mentioned, with in other words, the importance of integrating the concept as we're working on and several aspects related to health technologies. I would add, from your experience, it's a large experience, and also Ricardo, I can see there are several gaps when in the countries that they are not adopting this integrated approach. So, for example, some countries that are already making good assessments of the technologies and supporting decision making, they are not taking care of monitoring the appropriate use of the health technologies. I talk health technology in general, but of course our focus today is much more on devices. Not talking about medicines today, but what I'm saying is more in general comments in terms of the lack a integrated system that allow a kind of a feedback system when you can, based on information you get from monitoring the use of technologies, you can reassess decisions in terms of the incorporation into the health systems. So from your experience, have you been seen in the countries in the region some examples of this integrated approach, or you still think there's a lack of integration? Go ahead.
Well, the value of integration in terms of return to the community has been documented in research papers and studies, and one clear example is the waste of medical resources and expense for countries. In the U.S., it's about 30 to 40% of our costs, which is almost $1 trillion, unfortunately, in waste. And I think that 30 to 35% waste is found all around the world. The most recent report that I saw from WHO had a number something like that. So everyone is aware that we are wasting resources by not having systems thinking and systems approaches, closed loop or more closed loop information and control systems in healthcare. Achieving that goal is what this 21st century is going to be about, because frankly, all of our nations will run out of money at this rate. So as with many things, until the urgency is strong enough to motivate change, human nature is to remain with the status quo. If there's good news, it is that there are many more ubiquitous technologies like cellular communication and text messaging and WhatsApp that are becoming adopted around the world and allow integrated sharing of data, which ultimately allows ministries of health, the World Health Organization, PAHO, patients to share and have access to information. But very few countries are successfully doing this. Large enterprises like Kaiser Permanente in the U.S. Are in fact demonstrating this, and in the U.S. the Medicare environment and systems are demonstrating this, so that the proof of the tools working is becoming much, much clearer. The goal, or the gold standard that we want to achieve, is being defined by research, and now I think we're in the process of building the actual systems and training ourselves to support those systems. I'm not sure if that answered your question quite, but that's the best I can formulate at the moment.
Thank you very much. Yeah, definitely did. So I have now finally, I think we gave enough time to our colleagues to formulate the question. So I'm going to read here Dr. Sloane and Dr. Silva. So we have some greetings, saludos from Colleen Villarreal, Minister of Health, Trinidad and Tobago. So thank you very much, Colleen. And also Samael Williams from Turks and Caicos Islands, National Public Health Laboratory. So thank you very much for both for your participation. So the next it's from Simon Wifshire. Simon asks, for a small islands developing country, would you recommend the development of telemedicine to reach an aging population? Go ahead.
I would say yes. I mean, I have done training programs for PAHO in Dominica, in Barbados, I started in Trinidad and Tobago 40 years ago. I have traveled in Grenada, St. Vincent, probably 20 islands total, Jamaica. The travel time and distance through most countries is certainly not convenient, and the size of the hospitals and the health system is not very conducive to having everybody come. Yet you see people making their way by family car or bus to try to get care. The ability to intervene in a congestive heart failure, a chronic disease, a chronic obstructive pulmonary disease, with a very low cost and relatively immediate results does not require high bandwidth, doesn't require high expenses. The simplest of cell phones or text messaging can be used. So I think there's a high return on that. And I'll use my mother as an example. When she was in her latter phases of her congestive heart failure, I would call her every day, of course, but she would say, "Oh, I'm doing fine, I'm doing fine." But I would begin to hear wheezing as she was talking to me. And when I would get to visit her, I would find she was swollen with water. Her legs were like an elephant's legs. And she was kind of pretending she wasn't having trouble. But in fact, that is the exact syndrome that a person with congestive heart failure will go through. And if you can detect that weight gain quickly, you can provide Lasix or other medical support almost no cost, as opposed to what happened with my mother repeatedly, is she wound up being taken by ambulance to the emergency department, or she would have died. So I think there is a compelling argument for keeping a much more efficient and less expensive connection with the patient, family, and caregiver, so that we can reduce those kinds of very expensive and relatively dangerous challenges. So that would be my answer.
Thank you very much, Professor. So have we here in the chat Jenny Miller? It's Jenny Miller from South Africa. It's saying this is a great opportunity. Thank you very much. Thank you, Jenny, for your participation. Jenny Miller is one of the leaders, global leaders on health technology assessment on the board of Health Technology Assessment International. Thank you very much, Jenny, for your participation. I have a comment from Tom Jed, I think, and many Latin American, Caribbean clinical engineering universities professors are rewriting the CE Master's curricula to include digital health. So I think it's a great opportunity, and thank you very much, Tom Jed, for your comment. From Toby Clark, mentioned that it's so important to consider in IT and an integration of medical technologies, medical devices, network and telecommunications. And so thank you very much, Toby Clark, for your comment as well. It's a key and rapidly changing area to include into the assessment process. I totally agree. Thank you for your comment, Toby. Let's see, from Isabella Zuppo. Thank you, Dr. Sloane and Dr. Silva, for the webinar and the knowledge share. We are attending from Brazil at the CCATS, which is a Redetza member. It is located in the state of Minas Gerais, in the Federal University of Minas Gerais in Belo Horizonte, Brazil. So thank you very much, Isabella, for your participation, and for the other colleagues in this very important reference center for HTA in Brazil. Isabella and our colleagues, my greetings to all colleagues, Augusto and all the other. Martin Pauling, our biggest needs currently are policies and procedures pertaining to cybersecurity of medical technologies. Risk mitigation guidance documents would be beneficial. So it's a comment. Thank you, Martin. So later, if Professor Sloane can comment on that, it would be great.
I'd be glad to. Both Ricardo Silva and I teach security and cybersecurity courses at the graduate level, and we have curriculum for those kinds of courses as well. I mean, one of the thoughts that emerges is perhaps together with PAHO and IFMBE, we might put together quarterly study groups where we have a discussion on a specific topic like cybersecurity. And Ricardo and I can share our syllabi. We can share some of the resources that we use. Those might evolve into working groups that create some policies, best practices. It's not for us to dictate, but we have the information and we're more than willing to share it. And it can be bilingual. So, we want to take, that's why we're here having this discussion. We have cybersecurity is a particular area that we do have a lot of information about. There is a lot published. The development of practices, the best practices are, they've been part of banking and finance and government for decades, and we're now adapting them to what we're doing today. We're happy to work with you on that, and obviously, we couldn't, if we even wanted to, come to every country and do this teaching, but we can work with the faculty, we can work with the ministries of health. We should do it collectively, in my opinion, in some organized fashion, and again, I'd say over a very short period of time, work on each of these topic areas so that you have real in your own countries.
Okay, thank you very much. I have also another, let me see here with lots of questions now. Okay. Sorry, I lose the, okay, here from Simon, which again, in an environment which has a low penetration of digital devices, wouldn't the require culture change and then usage operability bar such an IT penetration of telemedicine in the community? I'm not sure if the, so I'll repeat the question. In an environment which has a low penetration of digital devices, wouldn't the required culture change and then usage operability bar?
I mean, there's no question that cultural change is a challenge in healthcare. It's a challenge in all technology. And there were physicians that didn't want to go to digital radiology. There are physicians that don't like the idea of computers doing automated diagnostics. All of that is true, and change emotionally, psychologically, equates to loss, and we resist it. But ultimately, our job, I think, as engineers, is to provide the technical solutions and engage in the discussion with the community so that the cultural and social issues are ultimately sorted out. I say in my role as a clinical engineer and information person, my job is to remove the uncertainty and improve the precision, accuracy, and reliability. All the rest of it is the kind of tribal discussion between the different medical specialists, the physicians, nurses, ministries of health. It's much more a cultural problem today than anything else. Technically, I can move zeros here to your country to Mars. I can move data now anywhere in the galaxy. That's not the barrier. The barrier now is cultural and environmental. And those are things we have to be part of that discussion. Part of it relates to developing national policies at the Ministry of Health level. And we're working with IFMBE CED to help develop some model telehealth policies so that individual countries don't have to start all over again and try to figure out, well, what standard applies for blood pressure. That ship left a long time ago. Don't waste your time on that. Let's help each other bootstrap that and then reach the bigger discussion about how many of our mothers and fathers, grandfathers and grandmothers do we want to have monitored at home, and how can we best support or afford that?
Okay, thank you very much. So coming to in 5 minutes to close our webinar. So I just have a couple of comments, and I have one from Tom Judd again. And mentioned that Elliot presented in Rome, that was the global meeting, about a policy on telehealth implementation global initiative for CED in 2020. He's suggesting that Elliot can describe this initiative. So go ahead.
Yeah, so what we would do in 2020, we would like to have volunteers, especially in Latin America and the Caribbean and Central America, to work with us to develop model policies that can be brought to individual ministries of health or health systems that would support telehealth deployment. Even in the US, a lot of telehealth is limited to pilot projects around a particular hospital or a particular city. What we need is a much more adaptable central standard that we can then bring to our ministries of health. You can translate to your local standards. What are your priorities for let's say asthma versus obesity and diabetes versus chronic heart disease, and then come up with a single set of standards in 2020, a single set of policy recommendations that can be massaged and implemented on a nation by nation, region by region basis. The idea, and we would very much like to have volunteers from your communities be part of this process, because it's really not us telling anyone how to do what needs to be done. It's us sharing our information and helping you work with your communities to develop policies that you are all comfortable with and know how to speak about and support.
Okay.
What's your effort in 2020?
Excellent, excellent. So I have and Mali HR is asking for the microphone. I'm sorry, I didn't see before. So Mali, can you make a question? I'm not sure if you have the mic. I ask my colleagues, Stephanie, can you release the mic to Nilda, to Mali?
Hi, good morning, Dr. Sloane. I want to congratulate. Yeah, good morning. I want to congratulate for your presentation. That was very informative and useful. I'm advisor in PAHO for Human Resources for Health. As you know, one of the big challenge at this moment for achieving the universal health is having human resources for strengthening the primary health care. And I consider that the proposal at this moment with the technology, e-health, telemedicine, is really very interesting to strengthen the capacity of the primary health care to provide the requested health care and quality of care that is necessary. My specific question is in relation with what infrastructure is required for the primary health care providers, and also the profile of this primary health care provider to really achieve in the implementation of this technology. Much.
Okay, very good question. Thank you for the question. The infrastructure can be very simple. Presuming there is a cellular network that supports text messaging, these kinds of systems could be built with text messaging. There's also a form of secure email called Direct that uses encrypted email that could be used. It depends on how the nation is structuring its primary healthcare network or system, and how large the obligations for the physician is, the primary healthcare physician or nurse or system. But we're using these kinds of systems in nurse-run healthcare centers in the U.S. And there are open source electronic health record software systems that could be adapted to this use. So it doesn't require a massive amount of infrastructure. It really depends on defining the goals, and probably you would want to have in a country a roadmap, a 5-year roadmap of starting small, crawl, walk, run, and the underlying technologies of text messaging, email, they're not going to change all that quickly. The ability to move data packets from one place to another securely is pretty well understood today, with a goal of eventually having automation of data capture. The cost of going immediately to data capture automation is probably too large for an individual city or primary care practice. But I don't. There's nothing that would stop data from being collected and flowing from very simple devices today. If you look again on Amazon.com, there are companies like iHealth who sell $35, $40 blood pressure monitors that are able to create a report in a PDF or Excel format that is a perfectly reasonable record. So there are ways to do this without spending a lot of money. One has to think about how do you do that in a longer term roadmap. A quick example: when I started in the medical equipment rental business 22 years ago, 25 years ago, we were faxing all of our rental records to our central office, and people were typing them. It wasn't very elegant, but it got the job done. Eventually, we moved on to barcoding and RFID. So these capabilities are inherent in apps and in smart technologies today. Telebaby is an example of a well baby and newborn support system that's based, I think, on text messaging. So I think we can look at all of those kinds of models to make this very lean and very fast.
Okay, thank you very much. And Mali, I'm sorry I didn't recognize your name. When I see, I didn't. It's Mali Cho, is my colleague here at PAHO, as a regional advisor on human resource for health. So Mali, thank you very much for your participation. I'm sorry I see Mali, but I didn't see your last name, so I didn't recognize you. So thank you very much for being with us and for your question. We are moving to our final and last question, and this is from Anna K. Is there, in fact, I think it's 2 questions. Is there an example case study where IT has been used to connect patient care in a developing low resource setting? What model of patient-provider care can exist in that situation, especially across countries, and what would be the funding model look like? Not an easy one, so go ahead.
Well, there's really several questions. In terms of individual, I think Mexico has case studies. Ricardo, I believe you have mentioned that some of the work you've done in Ecuador and Venezuela has covered some of those kinds of case studies. Do you have any suggestions?
Precisely last night, I was talking to Rosana Rivas. I was helping them with an innovation class in Peru. And one thing that we were talking about is that something that we have not thoroughly is the political impact of clinical engineering healthcare and especially in public healthcare. So one thing that we were talking about, and I could perhaps invite some of the colleagues present, is to write an article, a paper, where we could disclose what is the actual impact of clinical engineering for public policy and healthcare practices. So that is something that we have done, but we have failed to properly demonstrate and
Okay. I think Tom Judd has commented on some of the work that Kaiser Permanente has done to support this kind of care in Haiti. And there are other documents, and developing a list of case studies would certainly be helpful. The longer term challenge that we really want to work on is that many of these are individual pilot projects and they have not scaled. And then the second question that's embedded in there, which is really complex, is moving data across nations. We have challenges in the US moving data across states, let alone across nations. We have privacy concerns. We have organizational concerns. We have economic responsibility concerns. The best example I can provide is work that's being done in the European Union that has both a political and economic model that requires collaboration. It's been a long, slow journey, but the technical boundaries, I can move ones and zeros anywhere. We all can move ones and zeros anywhere. We can move an X-ray, a JPEG. We can move data. It is no longer, we are no longer limited by technology. We're back to one of the earlier questions. These are cultural issues, and these become socio-economic issues and political issues. And PAHO has had a long history of wrestling with that and communicating about that. And to your point, Ricardo, I think the part of the ethical and decision-making process is really not well documented, and I think we can probably work in that space quite well. But we do have some great potential, very short term. Doesn't take a lot of investment to stand up these kinds of systems, and it really, they're tender issues though. When you talk about people who are moving from one country to another and what the burden of care and cost, risks and responsibilities are. But it's not a technical boundary anymore. It really is not.
Okay, thank you very much, Dr. Sloane. I think we are coming to an end. I'm sorry for if I missed a few questions, but it's already 1:20, so.
Excellent. I appreciate the opportunity, and I'm grateful for everybody's input and for the chance to work together with all of you.
Thank you very much, Dr. Sloane. Thank you very much, Dr. Silva. It was a great presentation, great webinar. Thank you all for the questions, for the very active participation. I'd like to thank my colleagues, Stephanie, Wilmer Raté, and Nilda Enriquez, who always help me a lot with the webinar series. We have been already 30 webinars as a part of the DATSA program, and for this series that we are doing with FMBE, but also very successful. So thank you very much, Tanjod again, and Terry Clark, Dr. Sloane, Dr. Silva, and all of them been participating in this fantastic session. I wish you a fantastic end of the day, especially a great weekend with your families. Thank you very much, and I remember that the webinar has been recorded. It's going to be available in the PAHO YouTube channel and also in our PAHO website, and we can share the link with the participants, I suppose by Monday. Okay, so thank you very much for your participation again, and have a wonderful weekend. Bye-bye.
Bye, everybody. Thank you.